welcome everyone. We are so pleased that you can take time to join us for this webinar. My name is Adam Kalinowski. I'm the president of the Pan-European patient organization Dystonia Europe. Unfortunately, this year we had to cancel our live meetings and lots of things are put on hold. But there are things we cannot put on hold, such as providing you with the latest information about dystonia. And that's why we decided to launch a series of webinars. And this is the fourth webinar in our series. And today we will focus on what is new in botulinum toxin therapy of dystonia. I also suffer from cervical dystonia, so I'm curious to learn something new today. So enjoy your meeting, and I pass voice to Monica.
Thank you, Adam, and hello everybody. As you heard, my name is Monica Benson, and I'm the Executive Director of Dystonia Europe. Been involved in Dystonia Europe since 2007. And just like Adam, I am also a dystonia patient and receive botulinum toxin therapy. So I'm also very interested in hearing and learning more about this therapy today. And it's great to have this fourth webinar here and the two panelists that we have with us today. We have Professor Dirk Dressler, who is the head of the Movement Disorder Section, Department of Neurology at Hannover Medical School in Germany. And we also have our other panelist, Dr. Katarzyna Śmiłowska, from the Department of Neurology in Sosnowiec in Poland. And Dr. Śmiłowska, she will take care of all the questions that are coming in during this presentation. And when you submit questions, please use the chat box, and then we will answer, or Professor Dressler will answer the questions after the presentation. And the presentation is also live on Facebook, and you can submit questions there. And we will make sure that those questions also get to Professor Dressler. And I think that's all for me. So I give the word to Kasia.
Thank you, Monica, for your kind invitation and for presenting me. So just a few housekeeping informations. As Monica mentioned, I will gather all the questions that you will have during the Professor Dressler presentation. So please type them into the chat box. And then after the presentation, I will ask Professor Dressler for his opinion on that questions. And additionally, all of you that are on Facebook, then you can also have the questions there. And then we will have all the questions gathered together, and it will be all answered after this presentation. Thank you very much, and I am giving the floor to Professor Dressler.
Yeah, thank you, Kasia. Thank you, Monica. Thank you, Adam. Hello, Dystonia Europe. Hello and welcome to everybody in Europe and beyond. I heard that even some of our guests are coming from other continents. It's ever so good to be with you this time in this strange technical way, and I sincerely hope that very soon we can get back to the old-fashioned formats we are all so used to, with personal contacts and opportunities to meet at these meetings and to chat and to speak and to exchange ideas, rather than just here being connected with computers and stuff that is actually rather strange to me. But anyway, we have done a couple of these things before here at the department, so I hope that I will not behave too much as a computer idiot. So if we do mistakes, please apologize. And so with this, I think we better get started. We have quite a bit of material to cover today. As you heard, that we will be discussing what's new in botulinum toxin therapy. We have several aspects here identified, which I thought could be interesting for you. So Adam, please, if you could open my presentation so that we can get started straight away. Yeah. So next slide, please. Yes, thank you. I think before we start to talk about new developments, I think it would be good to just review what botulinum toxin actually is and what botulinum toxin therapy means for us as physicians and for you as patients. So this therapy is, I think that's fair to say, the backbone of dystonia treatment. It was developed some 40 years ago. It originally came out of ophthalmology, as you know, but very soon after its first use for therapy in patients, it entered the field of dystonia. And so the first patients treated were blepharospasm patients, cervical dystonia patients, you know all that. That is all stuff from the good old 1980s. And then really the breakthrough came in the 1990s when this therapy was registered in many countries and became an official treatment, if you want to say so. And we're all aware that we have rather high subjective improvement rates in the order of 70 or 80%. Of course, that's always difficult to say, well, what can we expect? It depends on the particular patient. It depends on the situation and what is an improvement, how far does an improvement go. You can try to employ scales, but I think it's quite a plastic and intuitive approach to say, well, patients give the therapy a number of how much improvement you receive, and that is usually in that order. So the adverse effect profile is very favorable, as you know, and over these many years with more than hundreds of thousands of patients continuously treated, also the long-term safety record is excellent. I think it's always important to mention this, you know, despite this original connotation that we're dealing with a toxin, the side effect profile, the actual side effect profile, the long-term side effect profile is much, much better than with any of the drugs we're using for treatment of dystonia or for other purposes. The big advantage here really is that the toxin does not enter the system. It only enters the particular muscles we want to treat. It stays there, and all these interactions generating adverse effects are not relevant here really to the treatment of botulinum toxin. So we think it's important to mention that botulinum toxin, as good as it is as a method, it should in almost all cases be combined with other treatment options, with other therapeutic measures. So, and I think that the best results from botulinum toxin therapy you only get when you combine it in a multifactorial and multidisciplinary treatment concept. So when people say, well, we want to come to your botulinum toxin clinics, I say, we don't have botulinum toxin clinics. We have clinics for treatment of spasticity, dystonia, other movement disorders. Of course, the backbone, as I said initially, is botulinum toxin, but we are not only botulinum toxin doctors. We are movement disorder people. We combine all different treatment modalities we have. We combine deep brain stimulation, we combine drugs, physiotherapy, all this, you may see this in later on in the presentation. So we are talking about a multifactorial, multidisciplinary treatment concept. That's important for us. The next slide, please. So overall, in a nutshell, what I just said, botulinum toxin is a powerful tool. Its efficacy and safety is determined by the physician, much less so by the drug. So having said that, we want to talk about drug developments. Yes, there are drug developments, but bear in mind that the key thing with botulinum toxin therapy is certainly not the drug or its development. It's the way it's used, it's the way the physician uses it, it's the experience of the physician analyzing the patient, doing the right diagnosis, having developed skills, experience with this. So bear in mind, really the key thing with botulinum toxin therapy is really the doctor, is your physician, is your counterpart, and the drug is a tool, as important as it is, but it's not more than that. So really, and that's the reason why a good deal of the presentation is actually covering not so much the drug only, but more the way it's used. So the next slide, please. So we will be talking about treatment algorithms. We will cover the way the toxin is actually applied to the patient. We will talk, as I just said, about recent drug developments. And in these strange times, I think it would be good also to reach out to what Corona does with botulinum toxin, what we can learn from botulinum toxin therapy when we are faced with the challenges of the Corona pandemic. So the next slide, please. Let me start with the treatment algorithms. The next slide. Treatment algorithm is a strange and complicated Greek word. What it means is the botulinum toxin therapy has many parameters. You know, the dilution, the number of target muscles, the number of injection sites. So treatment algorithm covers all the various parameters that we have in botulinum toxin therapy, and it covers the way we are connecting these elements. So how do we develop a long-term strategy? How do we get starting doses? How do we guide our patients through, you know, basically decades of treatment? How do you structuralize the patient-physician relationship? So all this is covered with this term treatment algorithms. So, and here with the treatment algorithms, we were faced basically with two or three problems, and I want to address our attention now to the three aspects in the treatment algorithms where I think some important progress has been gained over the couple of years. So we certainly had an unmet need with botulinum toxin therapy when we came to the issue of interinjection intervals. Interinjection interval is the time between two injection series. So patient gets treated, receives his injection series, and then there is a waiting time, and then the patient comes back, and the time between these two subsequent injection series, that's called the interinjection time. And most of you know that ever since the therapy was developed in the early 1990s, a very strong recommendation, almost, you know, chiseled in marble, was never do a therapy, never do a retreatment unless 12 weeks have passed by in the meantime. And when you ask me how this 12-week interval was developed, I can only tell you I have no good idea. It was just a guess. I guess the reason was that often 12 weeks was more or less the duration of effect patients had, and so it just came from clinical practice, I guess. Certainly, there was never ever a good study suggesting that it should be 12 weeks, it should be 11 weeks, it should be 14 weeks or whatsoever. It just developed very early on historically that there needs to be this 12-week minimum interinjection interval. The reason why this was brought up was that some initial studies showed that the more often you applied botulinum toxin, I must say at that time with the drugs as they were at that time, the more often antibody formation occurred. However, you know, as clinicians, we were faced with the problem that our clinical experience told us that these 12 weeks were counterproductive because we saw many patients where the duration of effect was certainly less than these 12 weeks, and obviously they were suffering, waiting for the next injection series. We did a formal study on that in 2014, and we clearly saw that 83% of the 59 cervical dystonia patients we studied at that time showed a decrease in the therapeutic effect time before the 12 weeks were over. So that gave us a clear indication that we had to address this problem of the fixed interinjection intervals. So next slide, please. And so what we did was we started a second study that came out here in 2017. And based on some considerations about the reduced endogenicity of newer botulinum toxin drugs at that time, that was incobotulinum toxin A, xeomin, we predicted that with this drug, with this improved endogenetic profile, we could apply this drug safely at intervals of less than 94 days or 12 weeks. And we selected patients with a definite clinical need for these reduced interinjection intervals, and we exposed them to xeomin treatment with these reduced intervals. We followed them up for at least 2 years. Some were even followed up for 3-4 years. They were followed up clinically, and they were followed up where necessary also with antibody tests and everything. And at the end of the study, it became clear that when we took this group of patients who had their injections actually on average after 69 days, so 15 days before the recommended 12 weeks interval, none of these patients had developed any problem with antibody formation or with loss of therapeutic efficacy. So from that, I think it was a robust study sample, 30 patients, long exposure time. Also the botulinum toxin dose they received was robust. We were not pre-selecting patients with artificially low botulinum toxin doses. We really had robust exposure, and still, despite that, none of the patients developed a problem when we reduced the injection intervals from 94 to 69 days. So what does that mean for patients who received this short interval therapy? When they, with their 12 weeks interval, receive an average of 4.3 injection series per year, 65 days each year are gained for them in a better therapeutic condition. So 4 times these extra 15 days generates 65 days each year with improved therapeutic effect for these patients. So I think this is a very clear message. You can substantially increase the outcome of your therapy, if where necessary, you introduce short inter-injection intervals, and that was published there in 2017 in a paper there with Journal of Neurotransmission. Next slide, please. So we have another parameter with the botulinum toxin therapy. Everybody knows this. You know, you get the bill from the pharmacy, or you get a copy of your injection scheme, and it says patient received 100 units, 200 units, 300 units, 400 units. So that's the total botulinum toxin dose. It's an important parameter for the botulinum toxin therapy. How much toxin have you used, have you spent in that patient on that office visit? Similar to what I just said about injection intervals, since the early 1990s, it became clear that the higher the toxin dose, the higher the risk is for eventual antibody formation. And then again, without any formal studies, again, without any scientific rationale behind, people said, well, let's say the upper limit the patient should receive is in the order of 400 units. That's also a number that you see in most registration papers throughout the world where toxin, Botox, Xeamine was registered. There were various forms of recommendations to limit the total dose per injection series to around 400 or so units. The second aspect was that, you know, everybody was in the good old days concerned that the toxin as a toxin could produce more than just the local effects, could produce systemic effects. The body as such could be flooded with excessive toxin and could respond with side effects. And that also was a concern that was part of the cause to reduce the total doses to these sort of miracle 400 mouse units. But again, being clinicians, seeing patients, seeing their problems, it became clear to us that this dose limits the potential of the toxin therapy, especially in patients with more widespread forms of dystonia. So if you're not only talking about a blepharospasm, if you're not only talking about an isolated cervical dystonia, if your patient has cervical dystonia with shoulder involvement, arm involvement, when you talk about hemidystonia or generalized dystonia, segmental dystonias, or similarly, when you talk about very severe forms of focal dystonia, very severe forms of cervical dystonia also there, we frequently see that a 400 mouse unit dose, total dose, is certainly not enough to effectively cover the problem. Of course, and that's a part of the reality patients are faced with. A lot of patients are underdosed. They still have an effect, but they never have the full effect they could have if the upper limits were pushed up and if the possible total doses would be exploited in order really to address the patient's problem in an effective way. So again, we did the same as before. We never gave up and said, well, this is, you know, it's a golden rule and we have to obey to it. We said, we challenge it, we look what's possible. Can we go higher up? We collected the data, and that was published in the next study on the next slide. That was this high dose study we published first in 2014. We took over several years of collection time. We took 100 patients with dystonia and spasticity. each patient was followed up for at least 2 years again. So we had a long enough observation period to see whether maybe even after several injection series, the immune system would respond. So it was at least 2 years in most patients. It was actually 4 years, 5 years observation period. So we collected this group of patients over a relatively long period of time. These patients were dosed as they were dosed because of clinical necessity. There were patients, as I said, with more widespread forms of dystonia, segmental dystonia often, or incomplete generalized forms of dystonia. Also the spasticity patients, we had patients with arm dystonia, leg dystonia, combinations of arm and leg dystonia, hemidystonia. We had tetraspastic patients. So that was the starting point. These patients had severe symptoms and they required a large number of treatment of a large number of target muscles, and also in substantial and robust doses. So that was how they ended up with total doses in excess of 400 units. You see 400 units, that was the inclusion criteria. Some of the patients had higher doses. I think on average in that group, the total dose was in the order of 600 or 700 units, but some even had 1200 or later on 1300 or 1400 mouse units. So, and at the end of the observation period, what we saw was again a very clear-cut, unequivalent, equivocant result. There was no indication of antibody formation, no loss of efficacy, and also there was no loss of systemic side effects. So we concluded it is possible, despite what all the people said all the time before we challenged it, no total doses of more than 400 units. So that was the birth time of the high dose therapy. And I'm happy to say that later on, these results were duplicated. 3 years later, a study sponsored by a company confirmed our results. They didn't dare to go higher than 800 units. I don't know why. I mean, I was a senior author. I said, why don't we include also patients with higher doses? But the company was afraid, and so it was a full confirmation of what we said, but not even actually reaching the extent of dose increases we dared to cover in our initial study. So next slide. So a third aspect from the area of treatment algorithm is what I said before. We are favoring, we are promoting, we are really peddling the idea that the toxin should be part of a multimodal interdisciplinary treatment approach. And it's very difficult actually to cover this in formal studies. You know, we cannot just take groups of patients treating in a multimodal way and other groups not doing this. Extremely difficult to match these patient groups. So what we did is we said, okay, we start very basic. We collect experience from people who are experts in the field. We bring them together and we ask them to help us to generate a consensus paper. And that is what I want to share with you here. Next slide, please. That was our pivotal paper we published in 2015. A group of 20 experts from many countries all over the world. You see from Europe, from South America, from Asia, from Poland. So from everywhere, we gathered 20 experts, and they all agreed on this paper and on the treatment strategies described there. And basically the idea was that we came up with a table based on severity and distribution of the dystonic symptoms, suggesting what kind of combination of therapy you should apply to your patient. Can I have the next slide, please? I don't want to go through the details, that would take us too long here, but basically you see the table consists of the dystonia localization and the dystonia severity, and depending on how these two elements are interconnected, we recommend do botulinum toxin therapy only very mild cases, very focal cases. If it's more widespread, add rehabilitation, physiotherapy, retraining, occupational therapy, all these elements can then be added. So that's basically the structure of this recommendation. If you want, you can go through the original publication at another point of time. But the key message here is we see, and all our colleagues joining us in this panel supported this idea that we see that at least in more widespread, more severe forms of dystonia, a combination of therapeutic approaches is helpful, and never see the toxin as the sole therapy. Also, an interesting aspect here is with the data from the high dose therapy that influenced this table here considerably. You know that initially people said botulinum toxin is only for this focal dystonia, so blepharospasm, maybe a bit of cervical dystonia. As soon as dystonia gets more robust, gets more widespread, then you have to switch your patients to deep brain stimulation. And here, this panel agreed that with the option of high-dose botulinum toxin therapy, it's clear that not every patient who has more severe, more widespread forms automatically have to receive deep brain stimulation. They have an option. If it wouldn't work, you could nevertheless later on switch to the much more invasive deep brain stimulation, but at least it makes sense to give them a trial on the much less invasive botulinum toxin therapy first. Next slide, please. So a few words on botulinum toxin application. You heard about this discussion, I'm sure. Next slide, please. Botulinum toxin therapy is a local therapy, so that means we need to inject the toxin into the particular target muscles in the appropriate doses. So that requires the process of planning. We have to identify which target muscles should be included in our therapy. We have to decide how much toxin they should receive. That together constitutes the injection scheme. That's what every patient bears with him, their individual injection schemes. You use that usually over time, you refine it, you adapt it when there are changes in the symptomatology, but usually once you have developed an optimal injection scheme, you tend to stick to it, not to fluctuate around, not to modify it too often. Refinement, yes, but not giving the whole thing certain continuity and reproducibility. That's very important for patients. So second step is, once you have that plan, the injection scheme, you have to actually apply the toxin into the target muscles. That's the process of placement. And there is an interesting hypothesis, and I say with all caution, this is a hypothesis, and later on you will realize that I think we have good reasons to believe that this hypothesis isn't even true. The hypothesis said that an exact location might reduce the botulinum toxin doses and might reduce the adverse effects. So from that hypothesis, this whole concept of, refining the placement process with technical means got started. Next slide, please. You see here basically the two technical methods we have to refine the application process is the ultrasound and the electromyography. Ultrasound is a machine where you have a handheld device that's put on your muscles, on your skin. It penetrates the tissue and it generates an image on a screen where you can see the muscles, where you can see also some vessels, some nerves, some bones, and so. Electromyography is a different method. It's based on electric currents. You know that all the muscles, when they work, they generate some electricity. And if you have a special recording needle, this recording needle can record the electric activity of muscles. And when the needle has a special feature, the tip of the needle records it, and when you get a signal, a muscle signal, you know that the tip of the needle is in a muscle. So you're not getting here with the EMG an anatomical image. Like with the ultrasound, you get an electric signal, and basically what the neurophysiologist looks for is, do you get a strong muscle signal? Then you know that the tip of your recording needle is in the muscle. And when you combine the recording needle with an injection needle, certain needles, special needles you need for that, then you can inject it. Then you know that your toxin reaches really the target muscle you want to reach. Again, all based on acoustic feedback. Conventionally, you're left with your anatomical skills. You can use your topographical information, so you know where certain muscles start, where certain muscles end. You know that in between there is a muscle belly. So topographical information guides you with the conventional anatomical approach. You have landmarks. You know that 2 fingers from the beginning of the muscle is the belly with a certain muscle. So lots of hints and tricks you can have to localize your muscles based on anatomy. You can palpate the muscle. Muscles are working, they move. So if you have skilled hands, you feel where the muscle moves, where the muscle is active. You can feel the size, the diameter. You can see, okay, this is a hypertrophic muscle, so must be a dystonic muscle. You have many other tricks. You can pull on muscles, you can stimulate muscles, you see the responses. So it's anatomy, but it's experience, you know. If you say, well, anatomy is all what a first year medical student tells you, how to find a dystonic muscle in the neck. Well, that's not anatomy. Anatomy in this respect here is anatomy in the hands of an experienced physician who has palpated muscles before, who has used all the tricks of the trade before. That's a comparator when you try to compare injections based on anatomy and guidance techniques like ultrasound and EMG. Next slide, please.
Sorry, I stop you for a moment here. I just want to remind our participants that they can ask questions during the presentation using the chat options, and the questions will be answered after Professor Dressler presentation. All right, so don't be afraid and don't be ashamed and ask the questions using the chat options. Or if you are on Facebook, just use the comments under the post with the live stream. Thank you. So we are going to the next slide.
Mm-hmm. So, and now we have the interesting situation that especially ultrasound was promoted recently very strongly, and people said, well, you need this, and without this, you're probably not being able to produce good results. There are few studies actually showing whether these claims are correct. And all I can tell you is, yes, there are very few studies showing that the precision of placement, the precision of the injection is increased when you control it with an image, with the ultrasound image, or when you control it with the acoustic feedback from your EMG machine. But the interesting thing is there are so far no studies showing that this increased precision actually translate into an improved result of your therapy. And I think that's a very remarkable finding. So yes, there is reasons to believe that you may be able to hit the certain target muscles more precisely, but at the same time, you have to realize that this increased precision does not translate into an increased result of the therapy. We think that this initial hypothesis that the increased precision also increases the therapy is not true, is obviously not true, unless we get a study showing the opposite. There are explanations to explain this unsuspected result. One explanation is actually a very basic and simple explanation. Everybody knows that when you inject the toxin, it does not stay at that very point where you inject it. It diffuses, that's the word. It covers muscle tissue around the injection site. It spreads throughout the target muscle. Sometimes it even reaches muscles outside of the target muscle. So there is this effect of diffusion, and then it becomes clear if you see that you have diffusion, then the increased precision of the injection site does not matter so much, obviously, anymore. Also, there's another interesting effect that was very early on discussed. We know from microbiology that an active nerve, an active muscle attracts toxin. So that was called at that time the auto-targeting effect of toxin. So again, if the muscle searches for the toxin rather than toxin searches for the muscle, then it becomes clear that this increased precision of the application does not necessarily generate into better results. However, we still think that there are several clinical situations where increased precision imaging guidance, EMG guidance is helpful. Those are muscles when you treat muscles in the forearm. Forearm muscles are very complicated. They're very small, very thin. In forearms, in writer's cramp, in musician's cramps, you often have dystonia forms where you only have involvement of individual fascicles of muscles even. And that's a typical situation where we would intuitively say, yes, if we can identify this very fascicle involved, this very individual single muscle involved, if you just hit this, that's clinically certainly an advantage. You leave out other muscles not producing side effects. You focus really your therapy on that. But again, that's a situation of forearm muscles. That's a situation of individual dystonic involvements in muscles. Reality is most patients, cervical dystonia, have an involvement of large groups of muscles and so on and so on. Second situation is sometimes in spasticity treatment or in limb muscle, dystonic limb muscle affection. You have deep muscles several centimeters below the surface, so your skills of palpating these muscles and so is limited there also. If the muscles are small in particular, then also imaging might improve your results and might be helpful. Children also is another different area we are not covering here. Next slide, please. Okay, so our opinion here is the use of guidance technique is probably overestimated. We have to be careful that if we think it would be necessary, it includes a lot of treatment centers who not have the technology, who don't have patients who don't have the money. So yes, it's good to have this. We have this also. But we are selecting only small groups of patients where the application of this technique actually improves our patients' results. To us, it reminds us a little bit on the situation we had at the very beginning of the botulinum toxin therapy, when everybody said, based on some neurophysiological concepts, we should inject the muscles in their innervation bands and not outside, and people were, trying 2 hours to identify the innervation bands within the target muscles. That was a very theoretical concept, which is completely abandoned in the meantime. And our feeling is a bit that some of the hype that was generated in the last years with ultrasound is going in the same direction. Okay, next slide, please. Now we want to move to something where I saw that already some of you people out there had dropped some notes on the drug development. So can we have the next slide? You need to bear in mind the background of the drug development. We are talking about money, we talk about markets here. And in fact, the botulinum toxin market is an extremely attractive, huge market. You see now that the latest figures indicate that we talk about $5 or $6 billion every year in consumption of botulinum toxins. Okay, 50% goes into aesthetics, but 50% goes into therapeutics. So this is a huge market. It's an attractive market. So many companies want to get into that market. And clearly we see as rapidly increasing international competition. Most of the developments are actually coming not out of America, which what many people think. The strongest competition is generated now in Southeast Asia and Korea. So a large number of manufacturers who have developed interesting products and who are trying very hard to get into the international toxins market. And the problem behind is this, every new product needs a unique selling point. You cannot just say, well, we have a drug that's as good as the drug we have already. So people say, well, then we don't need it. We have it already. So all the companies are in desperate need. If they want to enter the market, they have to generate a unique selling point for their project or their drug. And there are two main areas of competition here. That's when it comes to long duration botulinum toxin drugs, and also liquid preparations of botulinum toxin drugs. Those are features that have been used in the past or are currently used to generate unique selling points. Can you have the next slide, please? Let me first start with the liquid botulinum toxin drugs. You know that there is already for decades a botulinum drugs available that comes as a liquid preparation. That's Neuroblock, Myoblock, Rimobotulinum toxin B, as it's now called according to the FDA classification. What's the advantage of a liquid preparation? The advantage is actually very small. You can use it straight away. You take it out of the shelf, you pull it out of the container, of the glass vial, as we said, and you inject it. You do not have to reconstitute it. That means you do not have to add saline to it, mix it, and then apply it. So it's a ready-to-use form. That's the only advantage of a liquid preparation. So the time for reconstitution is actually saved. So you save a minute or 2 or 3 or 5, depending on how fast you are with your reconstitution of your drug. So that is actually the advantage of a ready-made botulinum toxin drug, a liquid preparation. At the same time, the liquid preparation generates disadvantages. One disadvantage is if the drug is already reconstituted, it has already a maximum concentration. You can dilute it downwards, yes, but you can't concentrate it more. And depending on what kind of concentration is preset by the manufacturer, you run into a problem. You want to have a high concentration in facial injections, for example, and the drug comes with a bigger dilution, so you can't concentrate it anymore. You can down dilute it, yes, but depending on what kind of original concentration it has, you cannot concentrate it. So there has also been other attempts to modify already existing botulinum toxin drugs into liquid formulation. So basically taking, and that was the only drug that, the only company that pursued that so far, powder needed to be reconstituted, and Ipsen as a manufacturer tried to develop a liquid version out of this existent drug. But that's a concept that's very problematic, because by changing your constitution, by making it a liquid preparation, you change key features of the drug. So that means that all the registration authorities worldwide would consider it a new drug rather than a modified version. That would include, you need a completely new registration process costing millions, taking years. So if you have already an existent botulinum toxin drug, trying to develop a liquid preparation out of this doesn't seem to me a very logical thing. Additional problem is, and that is exactly what happened to Ipsen, was that their liquid preparation was different from the original Dysport registration. And then they had 2 drugs in their portfolio, Dysport original dry, Dysport liquid, and the dosing was different, and then the consumers, the customers, would have been completely confused. So next slide, please. So liquid preparations is something that maybe in the aesthetic area, if you develop a new drug, may be attractive. You can take it, maybe a pre-filled syringe even, you inject it as such, but it's only advantages for the physicians, for the customer, but not for the patient. You know, the patient at the end receives the neurotoxin contained, and it's not an advantage for the patient if the doctor saves some time by not needing to reconstitute the drug before the use. So next slide, please. Another issue is the long duration issue. You have heard that there is a US company around who also wants to enter the international toxin market, and they have produced a botulinum toxin preparation where they claim that it would have a longer duration than other drugs. So that is, and they went already public with this. They are in the development process of their drug and the registration process. So they do some pre-marketing activities now, and their key claim for this drug is this is a drug that has a longer duration of effect. Okay, what would be the theoretical advantages of a long duration botulinum toxin drug? Okay, if it lasts 6 months rather than 3 months, you could cut down on your office visits as a patient. So that may be attractive if you say, well, I don't want to see my doctor very often, rather than going 4 times to see him a year. We go to see him only twice a year. if you consider this an advantage, then a long duration drug could be increasing your compliance and could make you happy as a patient. However, there are also disadvantages you have to think about when you talk about a longer duration of the toxin action. If you have an adverse effect, it will last longer than in a shorter duration drug. So if you have dysphagia, it can happen, 5% of applications, usually lasts a week. If you have a drug with a longer duration of effect, this adverse effect would also proportionally last longer, maybe 2 weeks, 3 weeks, or whatever. Another issue is, and that has not actually been discussed so far very often, patients usually undergo a period of adaptation at the initiation of the therapy. So you start, you inject the patient, you see him back after 3 months, you take the results, you modify that. If you see the patient back not after 3 months, but after 6 months or 9 months or whatever, this adaptation phase also gets prolonged. So it takes longer before the patient is actually reaching the optimal, the phase of the optimal injection scheme. Okay, another issue is that shouldn't be, yeah, I mean, one other issue is, as I said, it limits the number of office visits for you with your patient, with your physician. A lot of my patients say, well, when we theoretically discussed about, you know, seeing the patient only twice a year, they said, oh, doctor, I don't like this. I like to see you. I like to come to you. I have many problems. You know, I need your advice. We talk about additional therapies. My symptoms change, and I like to see you 4 times a year. I don't want to see you only twice or 1 time a year. So actually, what could be an advantage, reducing office visits for other patients, is actually a disadvantage. And then a last thing that shouldn't concern you, you know, basically you are interfering with your physician's income if you don't ask his service as frequently as before. So I don't know, I mean, we are not involved in the economics here at the university, but other physicians might say, well, I don't like a drug where I lose my patients effectively. But okay, that's something the marketing guys of the companies have to consider. Another issue is it actually possible to produce a drug with a longer duration of action? Do we have a hypothesis? Do we have a hypothetical concept? Or is it just a claim, and is it not? Is it real, or is it you know? I must say, so far there is not any good concept how to prolong the duration of botulinum toxin drugs. Very vague ideas, yes, but not a concept that could be the basis of a special development project. One way is you look for different botulinum toxin types, you know, that they have different duration of action. But the problem is that the toxin type A we're using is actually the type with the longest duration of effect. And you might be able to identify toxins with shorter durations, yes, but so far, none of the toxin types seem to have a longer duration than A. So the concept, the hypothetical basis of a claim to have a longer duration of action is vague. And then the next issue is, okay, this company Revance is in clinical trials. So for that, they have access to clinical data. And when you ask and say, where are your clinical data to support your claim that your toxin is lasting longer, you see that they don't have these data. I'm very serious about this. I must say that the data they have generated are not proving their claim. I don't want to go into the details. It has something to do with the definition of the endpoint of clinical studies. It has something to do with the doses you are comparing. Of course, it's logical when you compare 40 units of Revance with 20 units of Botox. 40 units have a longer duration than 20 units of the reference substance. So these kind of things are actually very problematic here. So I must say, so far, and I'm very skeptical if it would ever happen, the claim of a long duration of effect of daxibotulinum toxin is not there. Okay, next slide, please. Next slide. Okay, so the need for longer duration drugs is unclear. The concept to achieve this is dubious, and the activity here for me is clearly generated from economic considerations rather than from unmet patient needs. Next slide, please. Okay, at the end now, let me just quickly run through a few thoughts about and observations about botulinum toxin therapy in the time of the corona pandemic. I want to separate the thing here into immediate effects and long-term effects. Immediate effects are relatively clear. We have a clear picture what happened now and what is happening now in the corona pandemic with our therapy. You know that the corona countermeasures, not the corona itself, has produced massive interruptions of social, economic, and medical interactions. And part of the medical interactions are shutdowns. So you know that in many countries, in many places, botulinum toxin therapy clinics have been closed because of governmental shutdowns. So that's also what happened here in our place. The government and the presidency of the medical school has decided to completely block botulinum toxin clinics for a period of 6 weeks in March, when the first wave of the corona pandemic reached the country indiscriminately. There was no question to prioritize patients who should continue to receive the therapy and others where the negative effects would be negligible. For example, it was an indiscriminate, complete shutdown for a period of 6 weeks. We took this as an experiment and said, okay, what can we learn for botulinum toxin therapy when patients are, completely deprived of the therapy from now to now. So within 0 seconds, therapy to no therapy at all. Next slide, please. And that was the Hannover corona study we did. Next slide. Next slide. Yeah. We studied 45 patients with questionnaires to see how they responded, what the effects of this shutdown was on their well-being, on their quality of life. We had certain inclusion criteria and so on and so on. I don't want to bother you with this. Next slide, please. 45 patients, they had various forms of dystonia, also pain conditions, chronic migraine, spasticity, and so on. Next slide, please. So what were the results? Due to this lockdown, the inter-injection intervals in that patient group was increased from 11 weeks to 17 weeks. So they had usually this 6 weeks delay in their treatment. However, 38% of patients had a delay of their retreatment much longer than these 6 weeks shutdown, because then you know, the system had an overflow and they got added up on a waiting list. And so effectively, quite a proportion of patients did not suffer only these 6 weeks of the actual shutdown, but also of a prolonged period of time until they could get back into the system again. Of course, they had a reoccurrence of their initial symptoms, muscle cramps, pain, whatever they had with their condition. And that's a hard figure here. Their self-described quality of life was reduced by 40%, you know. And interestingly, this roughly 40% decrease in quality of life was the same when the patient had blepharospasm and when they had cervical dystonia or when they had chronic migraine. So that's an interesting lesson we can learn here. Whatever we think how much the patient may be bothered by their condition does not necessarily reflecting the reality. A patient with a presumably mild blepharospasm can suffer as much as a patient with a traumatic cervical dystonia. So that was a somewhat surprising result from our study here. You cannot say as an outsider, this patient has a low burden of disease, not a serious case. No, it's the individual symptomatology, and that can be affected, that can affect the quality of life, even if the symptomatology does not look all too traumatic to the outside world. Another interesting thing is, if you ask the patient, how do you perceive the importance of the botulinum toxin therapy for you? Now that you saw it got stopped, it got interrupted, and after 6 weeks, you lost about 60–70% of the efficacy of the therapy. How do you now perceive the importance of this therapy for you? 2/3 of the patients said, now we realize how important it is. It's more important than we thought before. The other 30% said, okay, we had known it before already, how important it is, but 2/3 of patients said the shutdown told us even more drastically that we need this therapy. Another interesting thing is treatment availability is important, very important to all of our patients. The lockdown showed you that it's not only necessary to have a good therapy, but also that you get it in a reliable, predictable way. And apart from the shutdown, we are now experiencing an interesting situation in Europe. I mentioned myoblock, neuroblock before. At least in Germany, we had a non-availability of this drug now for more than 12 months. So, I mean, this is a disaster for patients who are relying on this drug if the manufacturer can't manage to produce it. So availability, stability of the treatment situation is a very important issue. And at the end of the day, patients, 98% of the patients said, we feel our patient rights interfered, violated by this indiscriminate lockdown. Why is it us? Why are not, for example, cancer therapies locked? Why are not, dialysis patients sent home? Why is it us? You know, there is no good reason why we are the ones who should suffer from these indiscriminate measures. Next slide, please. Next slide. And the very last word on the long term. Go back. Yes. One forward. So one last word on the long-term effect of the Corona challenge. Question marks. Nobody knows it. It's a completely new situation. However, I must say I'm concerned. I think the long-term results of what we are experiencing now will be dramatic. Certain things I could predict. What we see now is we clearly have a massively reduced exchange. We don't have meetings, you know this, you don't have meetings. We can't do projects. We can't go travel back and forth. We can't sit together, think of projects, exchange data. It's a massive interruption of the scientific exchange we see here. This means is a reduced competition. You know, I feel like as if the whole scientific system is currently paralyzed. We're all cocooning. We're all sitting at home. We all are self-sufficient, not, you know, feeling the pressure from the outside world, not interacting with our friends and colleagues and enemies. So we're all, you know, like frozen up in an ice age now. And I think psychologically, as a psychiatrist, this must leave traumatic traces in our social behavior and certainly in the scientific system as we used to know it in the past. Another very obvious thing is also, you know, when there are no meetings, there are no registration fees, no industry grants for scientific societies. So what will happen to the movement disorder society? What will happen to IAPRD if without meetings, they don't have their sources of income? They're not getting their revenues from membership fees. That's peanuts. They make their money from generating events, from registration fees and industry grants. And I don't see that the industry or anybody else would get back to this funding system as before. So what will, on a relatively short basis, actually happen to scientific societies? And of course, we also see that with all the money now spent on the economics, there will be a shortage of funding for the general healthcare system. It will dwindle. I mean, you can only spend the money once, and if it's spent elsewhere, the fight for resources in the healthcare system will increase. So cocooning, I mentioned already. Interesting thing is, from my work in China and other parts of Southeast Asia, Asia does not seem to be part of this trend. So my concern is that at the end of the day, we in the Western world will see that we get under increased pressure, economic pressure, political pressure also maybe from Asian countries now, because they managed to get through this pandemic crisis more elegantly than we did. And again, also that will also put more pressure on our healthcare system, because our healthcare systems are only as good as the money we make and the money we generate in our society. Okay, let me jump to the last slide for today. So we have seen some substantial progress in the area of treatment algorithms, short interval therapy, high dose therapy, multimodal therapy. We have progress with respect to imaging and guidance techniques for special indications only. We are in a highly competitive world of drug developments. However, sort of like Bill Clinton said, it's the economy stupid. I would say it's the dog, not the drug, stupid. So you as patients should always be careful when the industry hypes certain things. Be skeptical, be critical. Most of all, your therapy is decided by a good expert you have as a physician, rather than really by the companies selling you drugs. And with respect to the corona situation, wake up patients. That's a very deep concern I have. We will see more fights for patient rights. We see more competition for resources in the upcoming world. So patient organizations like yours will have to play a crucial role to defend the rights of your patients, to defend the economic basis of your therapies. That's all from my side for today, and I'm happy now to respond to your questions. Thank you very much.
Okay, thank you, Professor Dressler, for your very informative presentation. I think some of the questions were answered during the presentation. So, Kasia, very difficult task, and also Professor Dressler, you can start the Q&A session, please.
So first of all, Professor Dressler, thank you very much for this tremendous presentation, so informative and really brilliant. So thank you for this. And thank you all participants for all your questions on chat and on Facebook. So the first question will be about the daxibotulin toxin A. So Professor, do you think that if with the reduction of the number of injections, can we also reduce the risk of antibodies?
No. That's a totally different issue. I think it's important to realize that the issue of endogenicity has changed dramatically over the last years anyway. You know, basically all numbers we have about the frequency of antibody formation are data going back to I would say the 1990s. That's when most of the papers on antibodies and frequency of antibodies, risk factors for antibody formations were written. And it's now clear for us that the reason for that was that the drugs at that time were different from the drugs we have today. And all I can say is that the actual antibody problem today is a very small problem. If you ask me when would I have seen the last patient developing antibodies from our cohort here, years ago. The reason is, for example, Botox changed its drug in the year 2000. Not much was actually communicated to the outside world, but we know it from internal documentations and from some special publications. And it's clear now when you look over the time that this change of Botox was a dramatic improvement, a reduction in endogenicity. So the frequency of antibody in Botox, extremely low, I would say lower than % or something. For xeomine, you know, they have a special preparation of that drug without complexing proteins. There has not even been a single patient who had developed antibodies receiving xeomine. So with Dysport, the figures are not so clear to me. We're not using it very much, but even there, we have very few patients with antibody formation. I'm not saying that patients may not have antibodies, but the problem here is probably like with the corona testing. It's a big difference whether you say there is an antibody or whether it's a relevant antibody. And relevant antibody titers in patients are a very small problem. Your question is interesting. As I said initially, there were some original data that suggesting that the shorter the interval, the more frequent the application, the higher the endogenicity risk is. And if you then stretch the injection interval to a year or 6 months, theoretically you should be able to reduce the endogenicity in that way. But first, it's a non-existent or almost non-existent problem. And the second problem is, I would actually be more cautious whether this preparation of the drug is not actually generating more endogenicity than it can be made good for by spreading the interinjection intervals. So this drug so far has no relevance with respect to endogenicity. It bears, like all new drugs, actually an increased risk of having a high adigenicity, which is not detected until you actually expose large number of patients over prolonged periods of time.
Thank you very much. So if we are talking about the efficacy and the effectiveness of the injections, so why some patients do not respond on the injections and from the very beginning, and why some patients stop responding within time?
Yes. So you're talking about therapy failure in general, and it's now rather clear the reason for therapy failure are multiple. You have many reasons why a therapy may not produce the desired result. I mean, one initial problem is how much can you expect? You know, if you expect 100%, you're not satisfied if you get 99%. So a realistic treatment goal is a first step, and sometimes that is even a starting point. If a patient expects a complete reduction of the problem and gets only 99%, is that a treatment failure, or is it a problem with the expectation of the therapy? Okay, that is one aspect, the perception, the expectations, the patient side. The next thing is we have clearly the dystonia forms are very different. We have different localizations, blepharospasm, cervical dystonia, and within these different localizations, the subforms, you have subforms. In cervical dystonia, sometimes you have very violently shaking forms, myoclonic forms, and it's clear now that these forms are involving large number of muscles, are involving strong muscle activities, and that is the reason why these forms are, in general, have less favorable results than when you compare them to tonic forms. Tonic forms may look dramatic, but I usually congratulate the patients. If you have a tonic form, the chances that this gets better are higher than when you have violent shaking forms. Also, a negative or a difficult form is a lot of tremor. That is so difficult to control. There is always some remains of that tremor, and the patients are irritated by the tremor. So that's also a subform which tends to produce worse results. In blepharospasm, the key thing is associated eyelid opening apraxia. If you have this, that's the symptom the toxin cannot reduce. You know, the activation of the levator muscle does not get better when you inject toxin. So there are subforms that are associated with less favorable results. You can have patients with secondary complications if you have already, you know, arthrotic pain after 20 years of severe untreated cervical dystonia. Your dystonia may get better, but your pain due to other reasons, to secondary complications, may still be a problem. So, and then of course, to be honest, most therapy failure are physicians' failures. I try to explain to you in the presentation that is a very special therapy. We are not just taking a drug and apply it. It's the way we apply it. That's the key thing. And of course, the number of target muscles can be too low in general. It can be the wrong target muscles. Within the target muscles, the dosing can be too low. Your overall dosing can be completely inadequate. Sometimes we are surprised to see how far off the track some injection schemes are. I mean, I'm trying to tell you that you know, we are the gods and everybody else is stupid, but there is a certain, you know, decent therapy, and then there are remarkably many treatments where you think this is off the track completely. How could you even expect this to work at all? So my advice for patients is, before you give up the therapy, try to get at least a second opinion to see that some sort of expert says, okay, this is what we believe is the maximum you can get out of this therapy. May not always be 100%, but not taking a no as a no from the first therapist or from a less experienced therapist.
Yeah, I think that you mentioned two main points. First, the expectation of the patients. So the importance of the relationship that we build with our patients, and
Oh, yes.
explaining them how important is to have to meet with the expectations and the possibilities of the treatment. And second, that you always can have the second opinion, even if you are in movement disorder center and if you are treated with the expert in Dystonia. And of course, if this is not available, then you should look for one before giving up the injections. Okay.
Yeah, thank you very much. That's really important that you mentioned that again. You know, I don't want to end up as a sort of old gray guy now, but my experience over the years tells me really the job is to make patients happy at the end of the day, and there are many ways to do this. And okay, sometimes I have young assistant doctors and they say, well, you chatted around, you know, don't you have anything better to do than to chat with the patients? I said, well, out of my approach, that's the way it is. And okay, there may be patients who say, well, this guy is crazy, I don't come back. But other patients say, well, no, we enjoy it. We look forward that we meet 4 times a year, that we have the opportunity to exchange things, to synchronize, you know, where we are, you as a doctor, me as a patient. It gives me the feeling that you understand my problems. They ask me many things related or unrelated to the disease, but at the end, what matters is the whole package. It's not the toxin. Yeah. I mean, we have seen situations where I sometimes even thought, you know, how much of the well-being of the patient is actually generated by the toxin, how much is the setting. Yeah. I mean, I'm a psychiatrist, and I can tell you, I had situations where I thought at the end, well, you know, toxin obviously hasn't changed anything. It was much more the setting. It was much more the guidance through, you know, the difficult situation. Yeah, that helped the patient. It's interesting, you know. Yeah. I'm not advocating a non-scientific and you know, evidence-based medicine here. Don't misunderstand me.
No, I think
at the end of the day, it goes beyond, and this extra is I think what often makes the difference.
Yeah, I think because of the acceptance that you would give to your patients, because you are the one who treat them, but they can only be true themselves. I mean, that they feel comfortable having chat with you.
Exactly.
About
and that was actually when companies, before they embarked on these long-term duration projects, of course they go around and speak to experts, and I said, you know, interesting thing, yes, your argument is well taken. You know, patients should probably be happy to say, well, I don't have to travel to Hannover 4 times a year, I only go twice. But afterwards I spoke to patients and I said, you know, what would you say if I would say, okay, we see each other only twice a year. Okay, there were patients, mild symptoms, bit of blepharospasm. Mm-hmm. They are in and out, nothing else, that's it. but a lot of patients, they say, no, we appreciate the contact. It's part of the setting, it's part of the concept. And so I'm no longer really so convinced that for everybody, reduced doctors' contacts would really be an advantage. Again, maybe in aesthetics it's different. Okay, they don't talk, they want the shots and that's it, in and out. But that's not the clientele of patients I have in my mind, and which are the majority of the patients coming here to this place. Maybe there is a collection of difficult patients or of complicated patients, but that's the reality. And so the need for a long-term drug for me is not so clear, actually.
Okay. So if we are still talking about the brands of the botulinum toxin that are available, so the next question is there a difference in the treatment effects from the different Botox available? And do you give the same treatment for different kind of dystonia, meaning the same brand of the botulinum toxin to your patients, or you change it based on which dystonia they are presenting?
Yeah, that's a very good question, because of course everybody wants to know this, but it goes back to what I said at the end of my presentation. The drug plays a minor role in the whole treatment. It's the doctor, it's the setting, it's the extras, it's the package. And I could be provocative and I could say each and every botulinum toxin drug, as long as it belongs to the group of toxin type A drugs, has the same effect. It has the same effect. It's botulinum neurotoxin which does the trick. And there is no difference whether it's the neurotoxin in Botox or the neurotoxin in Xeomin or the neurotoxin in Dysport. When you talk myoblock toxin type B, that's a different story altogether. But at the end of the day, the differences between the neurotoxin in Botox and the other toxin type A drugs are minute. They are sometimes even based on the very same breeding strain, Hall A strain hyper usually. And so when you see differences, it is first of all the difference between Dysport and the rest of the world, because they, for very strange reasons, have a completely different labeling system. You know, their units are not comparable directly to the units of other drugs. So when you have a patient with Dysport, always the question is, you know, if he responds differently, is it that he just didn't receive enough drug because the 100 units he had originally with Botox are not equal to, you know, 200 or 400 or whatever in Dysport. So that's some difference, clear difference. But if you find the right dose in Dysport, it works in the same way as with Botox, and it even more so between Xeomin and Botox. One-to-one comparable. You need 100 units Dysport, you give 100 units Botox, and the immediate effects are the same. With this drug, there is an androgenicity difference, probably, potentially, but as I said, with the absolutely low frequency of androgenicity, even in Botox now, this difference does not really seem to matter. So for us, between Botox and Xeomin, we don't distinguish. Maybe we would say if it's a patient with a high androgenicity risk, very high doses, very short intervals, then this extra androgenicity advantage maybe Xeomin has, would incline us to use Xeomin in that patient, but that is not really relevant.
Okay, so I see that we lost Dr. Kasia for a moment, I hope. So so before she come back, maybe I'll go with some other questions. I have one question actually in my case. After 8 years of receiving botulinum toxin type A, I'm resistant. I developed antibodies, so it's not working for me anymore. And now I'm on the botulinum toxin type B neuroblock, but for a while this type is not available in my hospital. So I want to ask you if I'm okay. We have Kasia, but I finished my question. So if I develop antibodies for botulinum toxin type A, if I'll do the break, for example, for a few years with receiving that drug, if I develop that antibodies for rest of my life, or that can work again after a few years break?
This whole issue of antibodies is actually a very interesting one, and we have done a lot of studies on that. We have published a book. I wrote my habilitation on that. It covers all the questions you raised. First question for us was, if somebody has antibodies, are they permanent or are they transient? You know, in a way, it's like now with the corona immunizations, you talk about antibodies. Patients have them after the infection, after the exposure of the antigen. Do they last or are they fading away? We were in the fortunate situation back then in the 1990s to get groups of relatively large group of antibody patients, like 40 or so patients. And we did follow-up studies, and it's so, I would say about a third of patients with antibody, if they are not continuously re-exposed, lose their antibodies within 2 years or something like this.
Okay.
They go down to irrelevant levels. They may not be completely gone, but the levels are so low that the therapy should be working again. 1/3 lose it after 2-3 years, and we have about 1/3, very roughly, about 1/3 who had them now for 5 years or even 10 years or something. So in your case, I would definitely say it would make sense every once in a while to repeat the antibody measurements to see where you are. And if the A antibodies you originally had are dropped to an insignificant level, you have an option to restart the therapy. We published a study exactly to this very question you raised, I don't know, 1 or 2 years or so ago. We took patients who had originally developed antibodies against Botox. Some years ago, we followed them up. When they dropped their titers, we said, okay, it's now possible that they respond to the toxin. And then the re-exposure we did not do with Botox, we did it with Xeomin, assuming this reduced antigenicity of Xeomin. And the surprising thing for us was that all of these, I don't know, 5 or 6 patients, when they were re-exposed to botulinum toxin in the form of Xeomin, they did not regain their original antibody titers again. So these patients are now on long-term therapy with Xeomin. They are happy, it works, and they have no antibody problem. So really, in your case, I would strongly recommend that somebody measures your antibody titers. There is a good chance that over the years they go down, and then when they are down, there is a very good chance that when you restart the therapy, that with Xeomin, that you are not building them up again. The original experience was that when that had happened like 20 years ago, and you re-expose that patient with Botox again after 2-3 injections, it would have gone up again to the original level. So that's why everybody said, well, wait till the titers drop and then re-expose them with the same drug. Doesn't make sense. But now that is really a very interesting indication for xeomine in this highly critical antigenicity situation. The advantage of xeomine may play a role by helping these patients to get back on a toxin therapy, which they would probably not been able to do with another drug.
Okay, thank you for answering. So it's actually good news
and by the way, the option with B is the only viable alternative. Don't believe when companies say, well, you have Botox antibodies, you try Dysport, it will work, or Merz comes and say, you have Botox antibodies, take xeomine, it will work. No, this is definitely not the case. There is cross-reactivity throughout all different toxin A products. So if you have them against one, it blocks all the others. So, but there is a lot of gossip, I know this, and that's just gossip. If you need a therapy, then B is the only alternative. But you're absolutely right. I mentioned that in my presentation. You know, the background is that this neuroblock came originally from Elan and was sold to Solstice, and Solstice sold it to US World Drugs. US World Drugs sold it years ago to Eisai in Europe. Eisai sold it to Sloan recently, and Sloan was not able, we have a handful of B patients here, we are not able to provide the toxin for at least a year now. I don't know when they will get back. So we got the toxin from international pharmacies, from remaining stock in Switzerland or whatever, and so a catastrophe for patients if a manufacturer offers a drug and then is not able to deliver it. It's a catastrophe, you know.
So it's not only an issue in the hospital.
No, it's not the hospital. No.
Okay.
No. We tried very hard. We have outside pharmacies, and we get the drugs from outside pharmacies, and they searched around. I don't know where they went, and they said, yeah, I think currently we got remaining stock from Switzerland, but they said this for the next patient, they will not be able to deliver it from there, so they are not looking for other sources. Maybe they think from America it may be an option, but there it costs double the money than here in Europe. But the problem is that the company behind is not stable and is not reliable, actually. And interestingly, but that's an anecdote, now in Europe for Sloan, the manufacturer of the drug substance for myoblock, neuroblock, will be actually Merz from Germany. But obviously, as much as they are involved already, Sloan is not able to deliver the stuff and to roll it out to the patients.
Okay, thank you very much. And welcome back, Kasia. So I pass the voice again to you. All right.
I'm sorry, some problems with the connection, but I'm back. So I think that we have the last question about injection in self. So the question is, what is the efficacy of botulinum toxin injection in musicians' dystonia, especially in windpipe musicians?
Yeah, you know, the musicians' dystonias are task-specific dystonias. Another task-specific, much more frequent dystonia is writer's cramp. And all these task-specific dystonias, they share one theme. It's very difficult to treat. you know, and particularly the musicians' dystonias are extremely difficult. You know, you must imagine that you have somebody who does tricks and things with his hands, his mouth, his lips, whatever it is, to a degree incredible for healthy people, you know, and then they have a tiny little bit of problem, and you should interfere there, paralyzing certain muscles and hoping that this enormous complexity comes back at the end of the day. I mean, I only see the results through my friend Eckhard Altmüller here, and sometimes we have initial patients, we then refer to him. I guess that there are patients who benefit to a certain degree. For example, that they can go to teaching rather than performing, you know. Clearly accepting a much reduced degree of perfection, but I don't think that you can manage to get a performing artist back to performing in public. So that's it's the challenge is just too big for them. Even a healthy person can usually not comply with this, and if you have this disease, it's difficult. Sometimes, you know, you hear patients that take a rest because of the therapy or unrelated to the therapy, and then they restart after years and they get back to a certain degree of functionality again. I think that is probably more an effect of the cause and the break rather than the therapeutic intervention.
Okay, thank you very much. So now we have a few questions about DBS, what it means, deep brain stimulation, and dystonia, and basically the injections of botulinum toxin. So if the patient have underwent the DBS, is there any contraindications to follow the injection protocol, to continue it, if there is, of course, the need?
Yeah, no. This is something what we described in this one paper I mentioned, and it's something what we practice every day. You know, Joachim Kraus, my friend and colleague, we're in the same spot here. We combine therapy. Clearly, both therapies are symptomatic therapies. There is no theoretical reason why you should not be able to combine them. You can combine them. Of course, one issue is, why did the patient receive the DBS? If the patient was put on DBS because he has an antibody problem, a proven antibody problem, and so on, and a stable antibody titer after the years, then it doesn't make sense to give him toxin that's blocked and will not be working. But, you know, there are patients who receive DBS for various reasons, may not be happy with toxin injections as such, or they got different advices, or they have complex forms or widespread severe forms where the toxin at that time also was not sufficiently effective. Those kind of patients you can top up very easily and elegantly with botulinum toxin. So especially, I would say, in very severe cases, you can take a lot of the dystonia load with the DBS and then refine it by approaching, you know, residual dystonic elements. So that's we should write a paper about this clearly, but it's all work and art is long and time is short. But clearly, I can tell you from a practical point of view, we have quite a collection of patients where we combine things.
Exactly. So the next question is pretty much the summary of what you already said. So there, one of the participants said that she or he has a generalized dystonia, and because of the generalized dystonia, she was treated with DBS, and she continues to receive the injection because of the cervical dystonia. And her question was whether she can also have the injection because she still has the hand and feet dystonia. So would it be appropriate also to combine it? So we can say that yes, this is something that we can already do.
And I would actually also add that whoever does it should bear in mind that the amount of toxin possible to be applied may be larger than what people still tend to believe. So we talking about an option of an additional 1,000 or 1,200 or whatever units available if necessary for such a patient.
So then we have another question. There is a participant who has Tardive Dyskinesia, and because of this Tardive Dyskinesia, he was treated with DBS, but currently was offered the focused ultrasounds. And the question is whether she should or he should decide for this treatment option, because I presume that DBS is not it's not effective, and it's Tardive, so it's very.
And in principle, I would say Tardive dystonia for us is actually a reason to first consider botulinum toxin, because you know that depending on the individual time course of the patient, but Tardive dystonia has a existent possibility that it fades away, you know, because the long-term follow-ups are a bit controversial. Do we have 50% recovery rate after 5 years? After 2 years, is it 70%? Whatever. But one key feature of Tardive dystonia is that there is a good chance that it gets better by stopping the exposure, of course. But if you do this, the good message for the patient is you have a chance that, unlike with idiopathic dystonia, you have a chance that it can get better. So that would incline us to say, okay, before we do sort of semi-reversible permanent DBS implantation, try to see what happens in the next year. You reduce the symptoms with botulinum, you hope that it gets better, and sort of say, in a way, you know, sneaking through in that way through the problem. But of course, there are permanent and definite Tardive dystonia patients. I cannot comment very much on the focused ultrasound thing. I know it's discussed in neurosurgery. I think both methods may have advantages and disadvantages. The nice thing with DBS is that you can modify it.
Exactly.
You know, you have the electrodes in place. You can change the stimulation point by changing the contacts. You can change the parameters. You can intensify it. You can reduce it. So it's a sort of adaptable system.
Right?
Whereas yes, and the focused ultrasound is basically an alternative to a destructive intervention, like what people did for 50, 70, 80 years by destroying certain areas of the brain, by alcohol, by heat, whatever, and this is ultrasound. I see a bit of a parallel. Some I would say 20 years ago, people tried to achieve the same by focusing X-rays, you know, in a similar way, you know, doing a three-dimensional array and applying X-rays, and in the focus where all these on the three-dimensional plane, these beams are meeting, you have a maximum destructive potential. But I must say, I thought that was very interesting because the X-rays can be focused very nicely, and so the specificity and the precision of that lesion should have been very high. But in reality, I was surprised that this option is completely abandoned these days. So I was wondering whether a much less focus beam like an ultrasound shock wave could reach a similar precision, could reach a sufficient precision compared to the old X-rays or even to the DBS. So I'm still very interested to see the actual results. I know that here Joachim doesn't do it. I don't know for what reasons. He may be waiting and see what the results are, but I wouldn't see a necessary advantage over a DBS if I would want to, you know, block a certain part of my brain. I would prefer the DBS rather than an experimental or still semi-experimental ultrasound approach.
Mm-hmm. Yes, thank you very much. And the other question is about the Baclofen pump. When it should be considered to introduce this treatment?
Yeah, Baclofen is actually an antispastic treatment originally. Was as an oral drug developed and as an antispastic drug. The intrathecal pump has the advantage that it can produce very high drug levels in spinal and supraspinal levels of the nervous system, and we use it frequently and regularly in spasticity patients, especially with paraspasticity, so lower body involvement. We were involved in a study, and we tried it in patient series in dystonia in the 90s, but we were overall rather disappointed. We had some remarkable success in I remember one particular very severe tardive dystonia patient. She had a strong positive response, but many others did not respond. So the general feeling, I would say, is that dystonia is not approachable by Baclofen pumps.
Maybe the pain, right? If it's the generalized dystonia, then this is a different indication, but not just for dystonia per se, right? So more for the other.
Yeah, I mean, also one situation may be that's a sort of a terminological problem. If you have somebody with a symptomatic dystonia, would you call it symptomatic spasticity? Would you call it symptomatic dystonia? So these kind of patients, if you have them in mind, I think there is an option, of course, that Baclofen works. But idiopathic dystonia, I don't think. I mean, if you are in doubt, it's not so difficult to do some testing. Also, if you want to push the testing to a definite limit, it's more invasive and more time-consuming. But in general, I would be hesitant to suggest that.
Okay, so we have just 2 more questions to go, and it will be also the answer for the Adam's question. So the first one may be maybe I will start with a bit more complicated. So again, one of the participants had her first injections in January, and then because of the Corona crisis, she couldn't have the additional ones because the clinic was closed. And she started to do the exercise combined with meditation. And then she had the injections in September, and she found that they were not that effective, that those in January, and that actually she felt worse, that she thinks that those exercises helped her a lot. And with the injections, the benefits that she had after the exercise just disappear or are lower than they were. So what do you think about it?
No, yeah, the first thing is 9 months is a bit of time in between. If it's a new dystonia, it could still be in a sort of developing phase, so that what we see now as the symptomatology may not be the same as it was originally in January. So that's one thing. I mean, what I don't think is that whatever therapy you may have done in between would have changed the response to botulinum. So, I mean, you could, of course, combine botulinum with relaxation techniques and yoga and whatever, increase to make it better, but that these therapies would sort of block subsequent response to botulinum. I don't think that could be anyhow explained.
Yeah. It was a difficult question. I think that this thing that you mentioned on the very beginning, that it is very important to have the multidisciplinary care.
Yes.
It's the key issue here. So it's not just the injection. It's
and you know, such a case, you would need to sit down and speak to the patient and see what happened in between.
Exactly.
You know, how was she affected with the Corona situation? What was the response really to the initial injections? And it would take a bit of time to really get an idea of what was really going on. You know, you have to remember that what patients say is how they feel it, and they use the words. They don't have the concepts you may have as a physician. So to translate what they say into what your categories are is often a bit time consuming, and the best to solve that is, that's my experience, to invest at the beginning of the therapy in a sort of similar information basis. Explain what the toxin therapy does. That helps really that you synchronize your languages, and that it makes it much easier later on to talk directly and quickly and rapidly to each other. So that's my experience at the beginning, investing a bit in the mutual understanding, synchronizing the languages. What's the side effect? What's too little effect? The classical problem, somebody says, oh, my head is worse. Yeah, is it worse because you over-injected, it drops, or was it not enough in an anticolis? So this is a classical problem. If you try to educate your patients and synchronize your languages, it's much easier to understand each other.
Yeah. So we have one last question. I thought that no one will ask, but here it is. So what do you think about the cannabis as a treatment options for dystonia? I think that it's a hot topic, right? It's coming all over in every disease that we can imagine, especially in neurological diseases.
Yes, yes,
so
yes.
What is your opinion?
I think it makes sense to revise a little bit the background of this story. You know, I would say the cannabis business at the moment is the hottest topic in pharmaceutical industry. I mean, it's really as such. It's a commercial thing. There are several companies making huge money with cannabis for various reasons. It's cheap to produce, don't need registrations, and so on and so on. So if you're out for the money these days, cannabis is really absolutely exciting for these people. I mean, cannabis has always been used in dystonia for decades. I mean, when you really have a good patient relationship and you ask your patients, younger patients in particular, and they say, well, you know, have you had experience with this? So find out that there is a long history of use of cannabis. I must say I was never excited. Most of the patients who gave me the story, they said they tried it, there was a bit of an effect, but it was like drinking alcohol, was not enough, and so they never followed it up, and they never pursued to get a medical prescription for that. I think really the evidence that it has antidystonic features is rather mild and low, and I think the kind of effect is a general relaxation effect, like with alcohol, in that order. For pain, it's a different story, and for maybe cancer pain and so on, so that there seems to be much stronger effects. And I mean, at the end of the day, I said to patients, well, you know, there are many ways these days to try it. If you think it works, then we can get back together and think how we can construct a medical prescription and all that. It's a bit complicated still, but possible. But I said it would not be worth to embark on this without having even actually tried it and having some evidence that it would make sense of it at the end of the day. So I'm not really enthusiastic, by no means. I think it's a bit hyped at the moment also, and it's really a hot topic, and billions in the market. It's a new market, and so it's pushed very hard, I guess.
And there are no studies with dystonia patients, and
not really that I know.
No.
Of course, there are lots of issues. Then, what's the dosage? There are different kinds of preparations. And,
Yeah.
You can always say, well, there was the relationship between CBD and THC was not favorable. The overall doses was not resolved appropriately, and a lot of things. Yeah. But I think if there would be stronger effects, then people would have done all that. I think it's. Yeah. For me, it wasn't worth spending the time. I said it was not enough evidence to really work up all the details and so.
Okay, so thank you very much. We do not have any other questions. I think that it was really a really long question and answer session. So thank you very much, Professor, that you agreed to take all those questions.
I think the advantage was with this kind of format, we could embark in a little bit more intimate relationship. So I was a bit on the long side with my presentation. Usual platform presentations in a real audience, I would have cut it down, but here I thought, okay, this format would allow us to go into a bit more detail sometimes. We will see, but it's certainly an experience for you, for me, and we can certainly optimize everything so that we address really the needs of our audience in the future. Yeah, so thanks for inviting me. All the best for the society, for you guys there, for the patients out there, wherever they are. Yeah. There is still ways for feedback. You can forward me stuff, or people can contact me directly.
I would like to ask you, Kasia, did we manage to answer all the questions?
Yes. Well, a few questions I answered directly in the chat, and but all other questions were well answered.
Wonderful. But
and Monica also, and then maybe that's of interest for the audience also. I was busy. I put the things together in an article, so you will have the condensed version of what we discussed this afternoon. You will have it available as an article.
But I also want to say thank you because this was extremely good, and seeing and hearing all the questions, it also showed that this is so much needed to have these kind of webinars where people can reach out.
No, I mean that's really also my experience. Especially we saw that when it came to the issue of the antibodies, there are lots of misperceptions of not knowledge, of misunderstandings, even in the medical community, and so it makes sense to try to clarify things.
Yeah.
And I don't know how long the article is. It will be maybe 2 pages or 3 pages, not too long. So we have in a nutshell what I said today.
Yeah.
We will have it available and give people a break. We do it for the next one, but it's ready, and you certainly get it before Christmas.
And I also want to stress this this survey that you have done with your patients in Germany.
Yeah.
Because of the corona pandemic and not being able to access the treatment.
Yes.
I think that's a very, very important survey and study that you did, and that we take that seriously.
Yes. No, you know, I went.
I think it's similar in many other countries, and I think it also differs from country to country. But
but there are remarkably many similarities, you know.
Yeah.
Many countries are more or less faced with the same situation. They just say, go home, go home.
Yeah.
And I mean, here the details are really terrible. There wasn't even somebody here answering the patient's telephone calls. They just said, automatic answer, we are not here, call us later, not even.
No, that's not okay, because I mean,
3 weeks, 2 weeks, whatever.
Yeah.
Nothing. Sorry, we are gone. We are not here. And I was really mad, and that's why I said, you know, I have to write this down to document this. And I went with the data to several patient meetings here in Germany, and I wrote articles about these data for German patient publications. I think it's really crucial. I was disappointed that after 40 years spending my time in Dystonia, there is still obviously in the public perception, even in the medical community, the idea that dystonia is a secondary disease. Nobody would have dared to send cancer patients home or dialysis patients home, but they were sending dystonia patients home. And botulinum toxin therapy, similar. Obviously, many people think it's something like treating wrinkles. You can do it, but you don't have to do it. You can leave it. It's not important. And that's for patient organizations important to change that perception. And I was surprised that after all the years of your efforts, my efforts, still, you know, what we do, what you suffer from is perceived as secondary, not important enough.
The dystonia patients in Germany, I know they're working very hard on raising awareness and public knowledge in profession.
And the result was, the first they skipped was dystonia and botulinum toxin therapy. I mean, other things also, but I'm exaggerating to some extent, but still, you know, I think it showed us where we are in reality with what we are doing, what we try to achieve. We have achieved things, yes, certainly, but obviously not enough.
And then my final word to you, because you said that we have been corona cocooning.
Yes.
I agree, and we are very sick of all of these Zoom meetings. But I do think that these webinars, it's a great interaction, and
Yes.
feel like we are connected, and I have meetings with all of you in my little office at home in Sweden, and of course we are learning so much. So if we have to do these things to make the best of the situation.
Yes.
And
yes.
after the cocooning, I hope that all of us, the medical profession, the patients, the researchers, the industry, they will be desperate to go out there, to go to meetings, to have workshops, to create projects, to get back into research, so that we are back in track and can move forward.
I hope that we can, as soon as possible, get back to this. I would certainly be on board if that happens. Okay. All the best. Bye then.
Bye.
Okay, so unfortunately, Professor Dressler, he just left. But anyway, I want to just thank to Professor Dressler and Dr. Kasia for sharing part of your evening with us, and for that real webinar marathon. It's our record. But I'm so happy. No. I'm so happy that you covered so much questions, and we got so much information. So we are very grateful to you, not only for the presentation and discussions tonight, but for the work that you do every day and helping with the Dystonia community. Also, I want to thank to our participants for the great questions and time. I want to let you know that a recorded version of this webinar will be available on the Dystonia Europe YouTube channel. So you can watch the presentation and Q&A again if you want, or you can share with others. And if you have any suggestions how we can improve format of our webinars, if you have any ideas for the topics for the future webinars, please contact us, Dystonia Europe, on Facebook or via contact form on Dystonia Europe website. So thank you, everyone. I wish you a Merry Christmas, and we look forward to having you in January at our next webinar. And thank you very much. Good evening.
Thank you. Bye.
Bye-bye.
Thank you. Bye.